इसको कैंसिल कर दे, बंद कर दे इसको। ईमेल नहीं चाहिए, ये बंद कर दे। हाँ। Good evening, friends, and welcome back to the Thursday evening PG teaching session brought to you from Sion Hospital, Mumbai. We thank the authorities at the Sion Hospital for allowing us to conduct these classes here, and we thank Aristo Pharma for their educational grant which helps us to live webcast these classes. Today we have two cases. The first case is being presented by Dr. Diksha from SRCC Hospital. So we'll start with that case. Dr. Diksha.
Good evening, everyone. I would be presenting the first case. So, a 1 year, 7-month-old male child, second by birth order, born of non-consanguineous marriage, Hindu by religion, hailing from Orissa, brought by mother, who is a reliable informer with complaints of a bluish discoloration of lips and nails noticed from 7 months of age. The child was alright till 7 months of age, taking feeds with normal personal history when mother noticed that the child had bluish discoloration of lips and fingertips, which became more evident when the child is crying. There is also history of episodes of sudden darkening of lips after excessive crying, followed by sleepiness. The episodes are less frequent than earlier. On further asking, there is history of active playing for some time and then resting with knees folded, and then again the child plays. During the follow-up visit for above complaints, it was noted that the child is not gaining weight adequately. There was no documentation of weight before the visits. For the above complaints, they visited a doctor where on examination murmur was heard. 2D echo done was suggestive of some heart disease. The child is now admitted for surgical correction. There is no history of acute onset or recurrent fever, cough, fast breathing to rule out respiratory pathology or increased pulmonary blood flow. There is no history of any drug intake to rule out any acquired cause of methemoglobinemia. There is no history of persistent cyanosis from birth and prolonged sickness to rule out congenital methemoglobinemia. There is no history of loss of consciousness, jerky movements to suggest severe spells, syncope or seizure disorder. There is no history of fever or focal neurological deficit to suggest the history of brain abscess. There is no history of facial puffiness, pedal edema or oliguria to suggest cardiac failure, and there is no history of prolonged fever, joint swelling, petechiae and painful finger pads to rule out infective endocarditis. Past history, there is no history of significant hospital admissions. Family history, there is no history of congenital heart disease in family, no history of sudden young death in family. Antenatal history, second child booked case detected by UPT at 2 months of amenorrhea was confirmed by USG. In first trimester, there were no complaints of fever with vesicular eruptions, drug intake or radiation exposure. There were regular ANC visits. Second trimester, quickening felt at 5.5 months. Regular ANC visits were done. Received 2 doses of tetanus and iron folic acid supplementations were taken. There is no history of any complaints suggestive of PIH or gestational diabetes mellitus. Third trimester, continued to perceive fetal movements. Regular ANC visits. No history of any complaints suggestive of GDM or PIH. Natal history, normal full-term vaginal delivery conducted at hospital, second birth order, baby cried after birth weight was 2.5 kg, BCG, OPV, hepatitis B vaccine given and vitamin K was received, breastfeeding initiated within 30 minutes after birth, no history of NICU admission, cyanosis, icterus or respiratory distress at birth, passed meconium and urine within 24 hours of birth, exclusively breastfed till 6 months of life. Dietary history, breastfeeding continued 2 to 3 times in a day for 10 to 15 minutes. Breakfast, 1 to 2 biscuits and cup of milk. Lunch, half to 1 chapati, half bowl of dal and rice. Evening, dalia or suji. Dinner, half to 1 bowl of khichdi or rice. So the expected kilocalories are 840 kilocalories and the consumed is 460. So there is a deficit of 380 kilocalories. proteins expected are 9.5 grams per day, observed is 6 grams, so there's a deficit of 3 grams. Developmental history, gross motor, the child can walk without support, is able to draw lines, speak 2 word sentences, and plays with toys, so it is appropriate for age. Immunization history, complete till 9 months of age as per national immunization schedule. Socioeconomic history, belongs to lower middle class according to modified Kuppeswamy scale.
Okay, so what are your initial thoughts when you have a 7-month-old baby coming with bluish discoloration of lips or nails?
Cyanotic diseases.
Cyanotic?
Cyanotic heart disease.
Why not a respiratory disease?
From 7 months, it is long history. From 7 months of age, the child has. It could be respiratory also, unlikely at this age, because more common is.
More common is a different issue, but medically or logically, why this cannot be a respiratory disease?
It can be a respiratory disease, but respiratory disease usually acute. There will be acute decompensation if that is a respiratory disease. But here it is the symptoms are from 7 months, almost 1 year. So it could be heart disease, cyanotic heart disease.
No, one sec. You are saying that from 7 months to now is 7 months. That's why not respiratory disease. That's what you are saying.
Long history is there.
No, so what are the different 2 kinds of respiratory diseases which can cause cyanosis? 2 groups.
Parenchymal and
That's about the pathology, acute and chronic. So you are saying this is not acute respiratory disease, which is fine. Why this can't be a chronic respiratory disease?
So chronic respiratory disease would have symptoms of on and off cough and breathing difficulty throughout. And
okay, so one is that there would be a
sick child. It would not be a comfortable.
Not necessarily a sick child, but the point is that there would be some history preceding the time when cyanosis was first seen, right? So what is your prototype of a respiratory disease which can have cyanosis? Chronic respiratory disease. What is the prototype? What do you have in mind?
Interstitial lung disease.
Very good. So now how will interstitial lung disease first become symptomatic, and at what point will it get cyanosis in the story?
Initially there will be breathlessness.
Take another mic. Take this.
Initially there will be breathlessness, respiratory distress, everything will be there, and over a period of time there will be the saturation slowly drops, clubbing develops.
So there won't be initially breathlessness and respiratory distress. See, interstitial lung disease is a slowly progressive disease. Now at this age, there could be a initiating event. So you could have a big illness in the beginning, which is then followed by persistent problems. Or it could start suddenly. So you should have a big neonatal issue or soon after birth issue, following which symptoms or signs linger. Or even if it is de novo. So initially there is effort intolerance, subtle, how infants would show. Then there would be gentle or mild tachypnea. Then you will get to cyanosis, right? So that's the progress in general of a interstitial lung disease.
So I think the cyanosis is a late event in a respiratory problem, whether acute or chronic, but a late event. And much before that, in a chronic lung disease, there is a tachypnea which may not be noticed, but still there is a failure to thrive. There is an exertional dyspnea. Okay, the child doesn't want to play, he is sedentary. Now that is a clue that he is not up to the mark on his oxygenation, but cyanosis has not yet appeared, and cyanosis is never a presentation of a chronic lung disease. Much before that something is happening. Cyanosis is an end result. And if this child is not sick prior to or at that time, there is no question of a respiratory cyanosis at all. And you said methemoglobinemia, it was a good you put all that, but that also showed that you have made up your mind that it is a heart disease. So you said no bacterial endocarditis, no brain abscess, which means you have made a diagnosis and then asking a question. Okay. So you would have started thinking, could it be a methemoglobinemia? Yes, you put it rightly. No respiratory, show cardiac. Now tell me, the baby was all right in the first 7 months. So I feel it's an acquired heart disease, not a congenital heart disease. Now you tell me, why do you call it a congenital heart disease? Hold it close.
Sir, initially the anatomy is such that maybe the obstruction is not that severe, and there are some other PD or something connecting providing the oxygenation. Maybe that's why the cyanosis became much evident at later in life and not at birth.
Fine. So a cardiac disease, yes, you said right. Is there any cardiac disease which is acquired, okay, and has cyanosis? You know rheumatic heart disorders, okay, you know valvular problems, you know myocardial problems. Which one will present as cyanosis?
Any thoughts? Any acquired heart disease which can present with cyanosis?
In other words, which cardiac disease can acutely present in a cardiac failure even with cyanosis? It's not acquired, but it is acute. And therefore I want you to differentiate. There is no acquired heart disease which comes with cyanosis. It has to come with breathlessness first.
At the most you can argue that somebody who is in shock comes with peripheral cyanosis, but not central cyanosis.
Okay. But, so now we know that this cannot be an acquired heart disease. This has to be a congenital heart disease. Correct? Now tell me, is it a shunt disease? Is it a valvular disease? Or is it a myocardial disease? Now we are going to microanatomy.
If it is a cyanosis, then it is most likely a shunt disease.
Why?
So, because if in cardiac case there is a cyanosis, then there has to be shunting of blood from the right side, from the left side, right side to the left side, which is causing deoxygenation. And
correct. So myocardial disease will not cause cyanosis. Again, it will cause peripheral cyanosis like we discussed. Can a severe valvular disease cause cyanosis?
Pulmonary stenosis.
Pulmonary stenosis, or you would like to use another word? Is pulmonary stenosis a cyanotic lesion?
PH.
No.
Arterial hypertension. If it is,
So push pulmonary stenosis to a higher degree. Pulmonary atresia. Okay, but cannot survive. Again, there is a shunt. So in other words, no valvular disease by itself presents as cyanosis. No myocardial disease presents as cyanosis. It presents as a cardiac failure. Okay. And one of the cardiac failures in a young infant, this is also a young infant, but even much before that, at 2-3 months of age, is Al-Kappa. And don't forget that there is nothing to suggest a heart disease, but it's an acute myocardial disease, and often we will just brush it out as a viral myocarditis. No. And Al-Kappa is surgically correctable. Okay. So we should not forget that. So now we have said it's not myocardial disease, it's not a valvular disease by itself. So it has to be a shunt disease. Okay, and as you said, right to left shunt. Now tell us, why did it not present in the first 7 months? right to left. Okay, at birth you have a right ventricular predominance, and this child has got right to left. So he should have come up very early in life.
No, I mean, anybody else? She's presented a case. Anyone?
It depends on the whether there is how is the pulmonary hypertension present, how much of the pulmonary circulation is present or not.
Yeah, so use better words. Don't say pulmonary hypertension. What will you say?
Initially, the pulmonary vascular resistance will be the higher. Once it decreases, then the flow increases, and then we can get the shunting and the sign.
Very good. So the amount of blood that gets shunted across the shunt depends on the relative resistance of the two circulations. So initially the pulmonary vascular resistance is not low, so there's not much of shunting, so that's why you are not getting sinus.
But more important reason for a late onset of a disease is the pulmonary flow is not too bad. Okay, a reasonable pulmonary blood flow, but not adequate.
So the second component is the degree of obstruction, which gradually increases with age, and that is why then you reach a point where the flow is less, the flow across the pulmonary valve or the outflow tract, and therefore the shunt goes on increasing, right?
So the intima starts getting hypertrophied, and then the stenosis becomes more and more severe, and then you start getting much more manifestation. But till then, excessive, when the baby cries, there would be a mild cyanosis, which is often missed. But this child had that story. Okay, why should crying make a cyanosis come up? I thought when the baby cries, he is taking better oxygen. He is breathing fast. He is breathing deep. Oxygenation is improved. Then how can a cry cause more cyanosis? A child with an acute bronchiolitis is breathing fast and often even crying as if nature wants him to breathe better for a better oxygenation. So why should a cry make cyanosis get...
Any thoughts on what happens?
Give a thought.
Because crying reduces the systemic vascular resistance, that in turn increases the shunting across the defect. So that causes more admixtured blood to go in the systemic circulation, and that's why enhance the cyanosis.
Very good. And therefore, when there is a mild cyanosis, it will be seen more often when the baby cries. Otherwise might be missed. And that is what is happening in this child, right? So we have already come to a conclusion that it's a congenital cyanotic heart disease. There is some pulmonary oligemia, and there is also a shunt. Okay, so we have already got those two components of a congenital heart disease, a shunt somewhere, atrial, ventricular, ductal, and a pulmonary circuit obstruction, which is getting worse on crying. Correct? Now tell me, what must be the other components, if at all, or this is enough? For example, I'll give an example. You have a VSD with pulmonary stenosis. That's what we have here, shunt and some pulmonary obstruction. Can this be a VSD with PS? Give a thought. We have come to conclusion there is a shunt, and ventricular shunt is most common. So let's take that as an example. And we have a pulmonary obstruction, VSD with PS. Can this be VSD with PS? What do you think, Akshara? VSD with PS. Just pass on the mic, please.
It can be a VSD with PS because of pulmonary obstruction. There should be, whenever the child cries, there should be infundibular spasm, and there should be reversal of shunt from right side to left side that can precipitate the cyanosis. So it can be a VSD with PS, sir.
So So VSD with PS, is it a cyanotic condition?
So VSD with PS is not a cyanotic heart disease, and therefore, if this child has got VSD and PS, there is some more component there. And what is that more component? A right ventricular hypertrophy. Therefore, the shunt is right to left. Normal shunt in a VSD with PS is a left to right. Correct? So now, we got the third component of a diagnosis only by history. You have a shunt, okay, you have a right-sided pressure which is reversing the shunt, and we have a pulmonary obstruction which is reasonably still flowing some blood. Fine? Now you got three components. Now tell me, with so many three complications, why is this child has not come with cardiac failure? Simple VSD comes with cardiac failure. Only pulmonary stenosis comes with cardiac failure. Two together, cardiac failure. Here three components and still no cardiac failure.
So there is overriding of aorta. So the right ventricular blood is getting shunted over.
So there is an outlet to the right ventricle more than normal. Fine. You got the history of a Fallot's physiology straight off.
Coming to the increases cyanosis with crying, when one cries, the intrapulmonary pressure increases. When the intrapulmonary pressure increases, the right-sided pressure should increase. When the right-sided pressure should increase, the shunt should decrease and the cyanosis should decrease after crying. Why does it increase at all? You got my point. When you cry, intrapulmonary pressure increases. So right to left shunt decreases. So the cyanosis should decrease. You said during crying, the cyanosis increases. Why should it increase?
You gave a reason, no? So what was your reason, Mike?
So two reasons. One was the systemic vascular resistance overall drops. So that acts against the intrapulmonary pressure. And second is infundibular spasm. So both of those things contribute to more blood getting shunted right to left and more deoxygenated blood getting shunted right to left, causing more systemic desaturation, causing cyanosis.
Yeah, so systemic resistance increases is one of the component. That pressure gets transmitted to the left side. And the second component is relatively less important.
Okay, now can this be transposition of great arteries? Wait, let someone else answer. You want to try?
So TGA of great artery, TGA usually presents at birth with cyanosis.
Very good. So TGA physiology, which is like parallel circulation, will present immediately at birth with deep cyanosis, right? Can this be something like a single ventricle or a truncus arteriosus? So there are three groups of cyanotic hearts. First one was what we discussed here. Second was TGA, which is parallel circulation. Third one, single ventricle truncus, what are they? Admixture. So can this be admixture cyanosis?
But not during birth. It will also present much earlier but not during birth, sometime after birth. And with failure signs.
Very good. So with signs of cardiac failure, and the cyanosis will be mild cyanosis, right? So this is low pulmonary blood flow category, and therefore this is Fallot's physiology, right? Very good.
Now, Fallot physiology does not tell us what correctly the problem is. Fallot's physiology is just the combination of this. Could it be overriding of aorta, that is Fallot's tetralogy? Could it be a double outlet right ventricle, that is similar to Fallot's physiology? Okay, we talked about transposition, okay, with PS, with VSD, that's also physiology similar. Okay, could there be a tricuspid valve problem? Therefore again, the pulmonary circuit is not open. So there are many types of Fallot's physiology, and he has already said it cannot be transposition with PS. Okay. Could it be a double outlet right ventricle as a part of Fallot's physiology? Fallot's tetralogy is different than Fallot's physiology. Okay. What do you think? Give a thought. You rightly said there is an outlet to the right ventricle. Okay. Now outlet could be a double outlet or an overriding. So could it be a double outlet right ventricle? Again, the manifestations would be very close to birth. Okay. Because nothing is going out of left ventricle. Everything is going out of the right ventricle. So manifestation of transposition with PS and double outlet right ventricle would be close to birth. Similar physiology. Whereas the typical tetralogy depends on how severe it is, and even if it is severe, it will present at 2, 3, 4 months, and sometimes you get what is known as a pink fallows. What is pink fallows? Cyanosis, child, and pink.
When the obstruction to the pulmonary outflow is minimum, then there is less shunting of the blood and more oxygenation, so that is pink fallows.
Very good. And therefore, pink fallows is a cyanosis which is subclinical. Okay, you don't see it, but you can pick it up by investigation. What simple investigation can pick up that he is still cyanosed but not visible? I'll give you an example. A serum bilirubin could be mildly raised, but still there is no icterus. But biochemically already a bilirubin has gone up. Could there be a simple blood test to say that, oh, he is hypoxic?
How will hemoglobin help? Very good.
Good. So, take a note of that. Sometimes such a child whom you have not expected to have a cyanotic problem, if for some reason a common CBC is done and you suddenly find a hemoglobin quite high as per expectation, then you start thinking that this is a silent hypoxia doing that. Okay. So tricuspid valve problems may come up similarly because the obstruction is that's not pulmonary but a tricuspid. Same thing happened, the pulmonary circuit is closed. And I think that is, and lastly, there could be a complicated syndrome. There could be, in a Fallot's physiology, some pulmonary artery branch stenosis, which cannot be picked up clinically or even sometime by echo. Or there could be not only VSD but also an ASD. Those things we cannot make out on clinical examination or sometimes even miss by investigation, right? So this is where it is. So can we see your findings? Summary of what you thought was that? You presented the negative history pretty well, but it told me that you are already diagnosed as Fallot's, correct? Whereas when you start history taking, you are not yet, but you are right. As you take the history, you start thinking what it is, and you very rightly put it. I am happy that now last 2 times the negative history has been justified by saying why you asked for it. I think that's a very good way to put it, and I don't think you put any extra negative history. It was good enough just. So that was a good presentation. Come show us your summary. Just before that, is there anything on the chat?
No, sir. Whatever we have discussed, fine. Same things.
Impression: a 1-year, 7-month-old male child, second born of non-consanguineous marriage, with normal birth history, with history of cyanosis evident from 8 months of age, with history of cyanotic spells, with poor weight gain, with relevant negative history, is suggestive of a cyanotic congenital heart disease, with moderate pulmonary outflow tract obstruction, with decreased pulmonary blood flow, most probably suggestive of Fallot's physiology, which could be tetralogy of Fallot's or double outlet right ventricle with VSD with PS.
Why did you call it cyanotic spell? Now you said that he squats and all that. I imagine it's difficult for parents to know that how to take care of a position when a cyanotic spell comes. Okay, maybe The earlier doctor said that every time he cries and gets more blue, you put him like this, but that is not easy. Okay. We said that crying improves cyanosis, no? Then what is this cyanotic spell? Is it a spell? And what is the difference between cyanosis appearing on crying versus a cyanotic spell? Give a thought. Any thought on that? Give a thought, doesn't matter.
Physiology of cyanotic spell.
Sir, actually there will be acute decompensation in pulmonary blood flow in previously compensated child. When the child cries, the peripheral runoff vasodilation happens and blood flow decreases acutely. So it will present with cyanosis.
So acute onset of a very severe cyanosis for no apparent reason, often happening early in the morning on waking up. Okay. And then you know the whole pathophysiology of it. At one time when we were students, we were told it's an infundibular spasm. It's no more than expect. So what is the pathophysiology of such a spell?
So what more changes happen besides
Metabolic
what?
acidosis.
Sorry?
Metabolic acidosis.
Very good. It's an acidosis. Okay. That makes changes in the vasculature. There is less blood coming out, the more blood coming out on the right side, increasing shunt and getting more thing. So acidosis is the major cause, which sets off the whole gamut of metabolic problems and that gut. Okay, probably this, the doctors previously might have said that whenever he cries and you put him like that, but that's a really almost never heard story. Okay, because at that time even the doctors may not know how to put the child, they are busy possibly treating it, maybe morphine or oxygen or whatever, right? So that is all that. And we have already discussed all this. Okay, good. Show us the... But before that, let's do one more experiment. Those who have not seen the patient, tell us what must be the weight and length of this baby. Guess. I'm just trying to show you how you can guess the weight and length also. You have 1 year 7 months,
Yes.
suffering from last say 1 year.
Yes, sir.
Okay, and the kind of suffering we already known. And she has given a diet history. Okay, what must be the weight? What is the normal expected weight of 1 year and 7 months? Yeah.
Around 10 to 12 kgs.
Not 12, 10, yeah.
Very small,
Huh?
towards 12. Okay, and what must be the normal length?
Normal length at this age would be around 85 centimeters.
Fine.
80, yeah.
So now, 12 kilos and 80, how much down you want to bring? Let's say first length. Could it be 80? Could it be 70? Could it be 75? Let's first guess that. Okay, what's your guess? And then justify your guess. It's not a toss of coin. It's a scientific guess. Give a try. I think you are doing that. Come on.
Sir, more than the length, weight would be more affected due to as this episode started after the 6-7 months, and after that the child's activity might have increased, and this is causing this spells. So I think the length should be less affected, so it would be around 80 or 70, 75 to 80.
Okay. What about others? What do you think?
Any thought? Make a guesswork. If this child was all right for the first 7 months, what must have been his length at that time? Length of a normal 7-month-old.
65 centimeter.
60?
5 centimeter.
67, 68, not 65.
67, 68. Even that time he may not be all that normal. But let's believe he is normal. So he is well above 68, and thereafter, how much does a weight gain occur between 7 months and 19 months? 1 year, 7 months. You get the question? What is the weight gain of a normal 7 months to 19 months? Not difficult.
6 kilos.
You don't. We already said 19 is 12, no? And 7th you said is 7, 8. Okay. So you would have got 4 or 5 kilos. So this child may have got half of it. Fine? And therefore, you would say that even at 7 months he must have been a little low, and thereafter he made only 3 kilos. Right? And therefore, if 1 month was 67, then he would have got to 71, 70 somewhere. Okay. How much weight you want to push him down?
Remember, there are two components here. One is the systemic disease and one is calorie malnutrition.
Both are, right? Now, all depends. The length, after all, depends on what the parent structure is, what is the mid-parental height. All that is accepted. But in the initial period, those things don't work. It's nutrition, right? So what must be the weight? How much down you want the weight to be? You want weight must have gone down even more than length, or length must have gone down more than weight?
Sir, he said weight is affected more than length.
Fine. So bring down that also. Now show us what is that. So that is one. What example? Do you expect a cardiac failure signs? No.
No.
No cardiac failure. Do you expect cardiomegaly? No. Fine. Do you expect a murmur?
Yes.
Do you expect a VSD murmur?
No.
No. Why? There is a VSD patient.
Sir, if the defect is larger, the gradient of the flow is well, so the murmur is.
So we are not surprised if we don't get VSD murmur at all. So we will get a murmur of outflow tract. That is all. Okay? Fine. So let's see now your finding. We have made some guess.
Which ventricle?
Which ventricle we have said? Right ventricle, because the flow is going across, right? Very good.
General examination. Child is lying comfortably in mother's lap, is active, alert, afebrile. Heart rate is around 130 per minute. Respiratory rate is 30 per minute. Saturations in all the limbs is around 64 to 67%. BP is 90 by 54 measured in the right upper arm in supine position. Peripheral pulses are well felt in all limbs, regular with good volume, no radiofemoral delay noted. CRT is less than 3 seconds. Cyanosis is present on lips and nails. There is no pellar, icterus, lymphadenopathy. Head to toe examination. Head.
You gave us the anthropometry.
Yes. So
you got it right? See, what is the power of even guessing the weight and length only on the history? We can't be absolutely half a kilo here and there, but we are reasonably there. Okay. So much so that when I was a resident, my teacher would say, no, you take the weight again, or your weighing machine is not all right. I said, sir, how do you know that? He knew how to justify a guesswork of a weight and length. Okay, that's the beauty of a power of bedside medicine, right?
Sir, there is one online question. How can we explain poor weight gain early in the course of cyanotic heart disease?
No, we cannot. The question is, why should a cyanotic heart lose weight? He will lose weight only if his metabolic rate has gone up and his intake cannot be maintained. So the question is, hypoxia itself is going to increase the metabolic rate. So that is one. But is he able to feed well? Is he getting breastfeeding? So that all will decide how much weight loss will come. But surely, if this child was on a good growth chart, somebody would have said that I think the breastfed baby should go up in the first 3-4 months. And your baby seemed to flatten out early. Somebody who has closely watched it would have picked up to say, no, are you getting enough breast milk or not? Or is there some hidden illness? Yes, I think we could have picked up on a growth chart slightly deviating. Look at the breast milk growth chart, breastfed baby, first 3-4 months going up and then flattening out slowly. Okay, that could have still happened.
And sir, another question is whether in cyanotic heart disease, height should be more affected than weight.
No, not really. Okay, the nature always serve in a manner its budgets. So when there is a severe malnutrition, the head circumference is never affected. Okay, because the head has to grow in the first 2 or 5 years, and thereafter the head doesn't grow at all, the brain doesn't grow at all. Then the height grows up to adolescence, but the weight can come up in life later. So nature budgets nutritional intake to head first, length next, and the weight last. I said head circumference is never upset by malnutrition. Tell me which one malnutrition upsets the head circumference? Just a catch question, but give a thought. There is only one type of malnutrition which affects the head.
Copper?
Copper nahi. Sir is not asking for the substance. The situation where you get a small head circumference because of poor nutrition.
When malnutrition starts in the first trimester of pregnancy, the brain growth is...
I want to tell you an observation. You make your own judgments. I always wondered whether brain growth is always spared. So what I did was, I found out from growth charts of Indian children and American children, same children having same birth weight, 3.75 kilos. So on the growth chart it showed that Indian children's head circumference at birth was more than that of American children of the same weight. But on first birthday, head circumference of Indian children is 2.5 centimeters less than that of American children. And this begins already at 6 months. So, and on second birthday, 9 out of 10 Indian children are malnourished. I think malnutrition affects everything. It affects weight maximum, height some, and brain growth least. But it does affect. We have a smaller brain.
See, what he meant was that the head circumference may not grow as normally as so. It may not be still microcephaly, but the functional element may be still suboptimal. So children in the first year of life who are malnourished, closer to infancy, closer backwards, are not going to be perfectly in terms of cognitive abilities. Okay, but they will still move in the society as near normal. But if you were to be a super intelligent, you would have been a normal intelligent. So some defect does occur functionally, but largely should not affect the normal life pattern. That's what we said. So it's the intrauterine growth retardation.
Also, when the nutrition is affected before birth, IUGR, there the head circumference is affected of the symmetrical IUGR rather than the asymmetrical IUGR.
Systemic examination, CVS, inspection, precordial bulge present, trachea appears to be central in position, apical impulse seen in left fourth ICS lateral to the midclavicular line, no pulsations or engorged neck veins visible. On palpation, trachea appears to be central in position, apical impulse felt at left fourth ICS 1.5 cm lateral to the midclavicular line, heaving in character, parasternal heave is present at left third to fourth ICS, no pulsations or heart sounds are palpable. On auscultation, S1 is normal, heart over the apical impulse, S2 is loud and single at the right second ICS, S3 and S4 are not heard. Murmur, ejection systolic murmur present, best heard at left third ICS, 3/6 of grade in supine position. Rest system are within normal limits.
So just go back and tell us all your positive findings, just tell us the interpretation.
Sir,
So Yeah, parasternal, no, even before precordial bulge.
So right ventricular hypertrophy could be because that could present as precordial bulge.
Right. So now suppose somebody has mitral stenosis with pulmonary hypertension with right ventricular hypertrophy. Will he have a precordial bulge?
So it is a chronic, so that's why precordial bulge is there.
Chronic and starting early in life. Okay. Yeah. Go on.
Then there's a shifting of the apical impulse laterally, which also signifies RVH. Then there's a murmur, ejection systolic murmur, which could be because of the pulmonary
Even
outflow
before
tract.
the murmur, you have some other findings, no? So what is this heaving apex? What does it tell you?
Pressure overload causes heaving apical impulse.
Very good. So pressure overload of the ventricle. Okay. Then
In this case, it should be right ventricular. In this case, it should be right ventricular hypertrophy. that is
right
causing-
ventricle. Okay, go on. Okay, so S2 single, what does it tell you?
Pulmonary stenosis.
So how would you answer it more correctly?
Soft S2.
So S2 single would mean that one of the two components is not there, either aortic or pulmonary. Now here in this scenario, it has to be the pulmonary component which is soft or not heard, right? Okay. Then what is this murmur signifying? Try.
Yeah, again the pulmonary stenosis.
Flow murmur due to the circulation, sir. Increased circulation through the
Flow murmur, where?
through the pulmonary wall.
Yeah. So it is a obstruction in that outflow tract which is giving rise to this murmur, right? Okay. Then other things are normal, right?
Yes, sir.
And you had a parasternal heave, you said, which was also right ventricular hypertrophy.
Yes.
Fine. So now tell us the diagnosis.
Summary: a 1 year 7 month old child, second born of non-consanguineous marriage with normal birth and development history, with history of cyanosis evident from 8 months of age, with history of cyanotic spells, with poor weight gain, with significant calorie and protein deficit, with examination findings such as lateral shift of apical impulse, ejection systolic murmur, is suggestive of cyanotic congenital heart disease with right ventricular hypertrophy, pulmonary outflow tract obstruction, with child not in failure, is most probably suggestive of tetralogy of Fallot.
Have you done any investigations?
Yes, sir. This is the CBC.
Okay, stay here. Can anyone read the X-ray?
Chest X-ray.
Yeah.
Chest X-ray, PA view. The apex is facing upwards, so it should be mostly right ventricular hypertrophy.
So before that, in order, what do you first talk about? You talk about whether the heart is large or no, before you talk of the right ventricle or the left ventricle. So what do you think? Is it cardiomegaly?
Cardiomegaly is seen, sir.
Okay. How do you decide cardiomegaly?
Cardiothoracic ratio.
Can you come here and show us how you do it? Anybody? You want to try? Come and show us on the screen. Come.
So we have to measure the width of the cardiac shadow from the midline to the left, maximum to the left and to the right, and if it's more than 50%, it indicates cardiomegaly.
Add the two and
Yes.
okay. Then what else? Go on reading. So there's cardiomegaly. Then
Yes, sir. Oligemic, sir. There is no pulmonary congestion. The child oligemic.
What else? Is the heart shadow looking like something in particular?
Boot-shaped heart.
So is this boot? Is it looking like a boot? You wanted a boot-shaped heart, but this is looking like?
TAPVC.
What is the appearance?
Figure of 8.
Figure of 8. Or snowman.
Snowman.
So, can there be some confounder? So that upper ka shadow, can it be something else which is making it appear like a snowman? Thymic shadow. So you have to, in the exam, talk of both. So you first say it almost looks like a figure of 8 with snowman appearance. So I would think of that, but then it could well be a thymic shadow.
I think also look at whether the X-ray is in good mid-inspiration. Sometimes if it's an expiration, then again whole thing goes up. But just to revise one, when you read an X-ray chest, go by A, B, C, D, E, F, G. A for airway, B for bones, C for cardiac, D for diaphragm, E for exposure, F for fissure, G for gastric bubble, H for hilum. Sometimes in an exam the X-ray chest is shown for some bony abnormalities, like a thalassemia measure. Okay. And the examiner wants you to pick up the changes in the ribs. So, A, B, C, D, E, F, G, H. You will not miss anything. Okay.
Repeat once more.
Okay.
A for A.
Okay. So,
He wants you to repeat ABC.
yeah. Okay. A for airway, B for bones, C for cardiac shadow, D for diaphragm, E for exposure, F for fissure, G for gastric bubble. Sometimes there could be a dextrocardial cytos inversus, so G for gastric bubble and H for hilum. So you will not miss anything, okay, and go systematically, right? Good. So what are you doing for this child?
One point, normally you don't see a thymic shadow in a child with cyanotic heart disease because it's a stressful situation right from the beginning and thymus shrinks in heart disease. Therefore, you are able to appreciate even the concavity because of hypoplastic aorta beautifully in the heart disease. Now, I don't expect this shadow to be due to thymus at all. Thymus has shrunk already. Stressful situation of 1.5 years. So, this shadow has to be explained on something else. That means the blood vessels have to be there, the aorta, the unfolding of aorta, everything, but something supracardiac, but not related to thymus.
And look at these two clavicles. See the turning. So all that you should say in an examination. I have a limitation of giving a diagnosis on this X-ray because this is not correctly positioned. Okay, fair enough. What have you done or what are you planning for?
So ICR, intracardiac repair. He's planned for surgical correction.
But 2D echo?
Yes.
Final diagnosis, please read out.
Large malaligned conoventricular VSD with bidirectional shunting, severe valvular infundibular pulmonary stenosis, confluent and good branch pulmonary arteries, dilated right atrium, right ventricle, normal biventricular function, no major coronary crossing RVOT anteriorly.
Good. I think we have a guest with us today. Please come here. He is a professor emeritus in Spain, neonatologist. He is here for a neonatology conference, and it is nice of you just to drop in to see what we do here and some comments on what happens at your end in Spain.
Well, thank you for inviting me. It's my pleasure to be here. I am an emeritus professor at the research institute, and I am a neonatologist, clinical neonatologist, and our main lines of research have been to study the physiology and the pathophysiology of the fetal to neonatal transition. So I was quite happy about the presentation today because it has to do, usually in few minutes everything changes from a series to a parallel circulation. I wanted to make a point which is quite commonly a matter of debate: hypoxemia and hypoxia, which are different concepts. The baby can have spells of hypoxemia, but usually not be hypoxic. If he is not gaining weight, this is more going into the diagnosis of hypoxia. The tissues don't work well, digestion is not done well, absorption of nutrients, synthesis of proteins, all this needs a lot of energy. If you are a part of the time into anaerobic metabolism, then you are not generating the ATP which is necessary for profiting all the income, all the input that you have as part of your nutrition. So I was perhaps, from my background, I would have gone more into biochemistry than you have done. But I think you are marvelous clinicians. I have enjoyed it so much. Thank you very much.
Good presentation and exactly to the point. Very well done. And I think take a note for subsequent presenters. She has shown that she has made efforts to prepare her presentation. Okay. It's not that, okay, you tell me to present, okay, here is my present. Okay, she has made efforts to put everything in order and perfectly done. I hope subsequent presenters spend some time to prepare it. Okay, it gives a very clear message to all of us. Okay, otherwise you have a technology here, you just pick up a photograph and put it there. No, it is well done. Okay, good. We have another case. Yes, thank you very much. You want to leave? Yes, thanks for coming here. Thank you very much. Thank you.
So we start with the second case, which is being presented by Dr. Yashodan from Sion Hospital.
Greetings everyone, good evening. I'm Yashodan Brahme. I'm a second year PG student in Sion Hospital. I'll be presenting a short case. So my patient is a 3-year, 11-month-old female child, 6th by birth order, born of non-consanguineous marriage. She is a resident of Govandi, Mumbai. She is hailing from UP. She is Muslim by religion, Khan by community. She was brought by mother, and the informer being mother. She has brought with complaints of generalized weakness since 15 days, reduced oral intake since 15 days, and increased work of breathing since 1 day. So on elaborating the history, the child was all right, absolutely all right 15 days back, when the mother started to notice generalized weakness. So on further inquiry of the history, she reports frequent falling and tripping of the patient initially, which was also followed by walking up and down the stairs at home with support. Initially, she used to run up and down the stairs. Now she walks slowly with support, very carefully. This weakness gradually worsened over the period of 2 weeks, and on the day of admission, the child was having difficulty in getting up from the lying down position and also rolling over in bed. So this was also associated with upper limb weakness. So that was initially in the form of difficulty in holding a spoon, and then later the child was not able to pick up things. So then both the limbs were simultaneously, both the upper limbs and the lower limbs were simultaneously involved as per the mother, and initially the lower limbs and later the upper limbs, as per this is what mother has explained. And the mother has also noticed reduced the mother has also noticed reduced oral intake. So reduced oral intake, but that was not associated with any oronasal regurgitation. That was not associated with difficulty in swallowing. That was not associated with any choking feeling. So the mother is giving generalized poor oral intake, and this was also associated. Mother also noticed increased work of breathing. So initially, the mother only noticed that the child is taking deep, slow breaths during when the child is asleep. And this work of breathing gradually worsened, and then it also started to happen during the daytime. So on the day of presentation, the child was taking very deep and slow breaths, which was noisy breathing according to mother. And was so this was how her work of breathing had worsened. So for these complaints, she had gone to a local practitioner, and some medications were given, some symptomatic treatment was taken. The details were not available, and but there was no relief of these complaints. So when the child presented to us, but there was no associated any history of but there was no history of any fever, there was no history of any trauma, there was no history of neck pain, back pain, there was no history of any tingling, numbness, there was no history of any oronasal regurgitation, there was no history of any bladder or bowel incontinence. And so there was no history that was suggestive of any cranial nerve involvement. There was no history suggestive of any bladder bowel incontinence. There was no history that was suggestive of any root pain or root involvement or sensory involvement. There was no history of COX or COX contact. There was no history of any recent drug intake. There was no history of any animal bite. There was no diurnal variation in the weakness also. There was no facial muscle weakness. There was no obvious deviation of eyes or change in the pitch of voice or hoarseness of voice.
So I think if you have gone through all of it, if anything important, then just tell us, otherwise we'll start discussing.
And there was no recent history of any respiratory or gastrointestinal infections, no history suggestive of any respiratory or gastrointestinal infections. So otherwise, ANC history is a registered pregnancy, uneventful ANC. Birth history wise also full-term normal vaginal delivery, baby cried immediately after birth, birth weight of around 2.5 kgs. There's history of NICU stay for 6 days in view of respiratory distress. Non-invasive ventilation was given, patient was not intubated, and then she was discharged on day of life 6. And she has been, and there are no admissions since. This is the second admission that the child had. Developmentally, the child is
even earlier. So are you all okay with the history, or you want some questions? You want some more information? So what's your thought process so far? So let me just take you to frequent episodes of tripping and falling. That was probably the first event as per the history. So what would you have thought of?
We can think of a loss of balance, so either a cerebellar involvement or a sensory ataxia sort of thing.
Okay, so one you think of is ataxia and cerebellar involvement. We'll discuss more and more, then we'll try and fine tune it. What else?
Nervous system also, its weakness is progressively increasing from distal.
Yeah, so the second part we'll ask him whether it's really ascending paralysis, but peripheral nerve as a cause of tripping. Why? You're right, but tell me why, explain.
First tell us what makes you not fall.
Vestibular involvement.
So vestibular involvement, suppose I ask you the other way around. What does a patient of vestibular disease come with? Will you say he comes to you for falls?
Mostly a vertigo.
Vertigo.
So you need a normal motor system, pyramidal tract. And what is that? Power, tone, incoordination, abnormal movements, nutrition. Anything upset, you will fall down. You need a sensory system and you need a cerebellum. So there could be so many causes. Do you need a vision? Of course you need a vision. So if somebody says, I'm falling down, he could be getting blind. So give a thought why we don't fall down or trip down. So you have to have an entire motor system, even sensory system, cerebellum, and to some extent you said also the inner ear, but the presentations are different, right?
Or higher centers, this child could be having drop attacks. He suddenly falls and gets up. Maybe transient loss of consciousness is a manifestation of seizure. He falls and gets up. Loss of sensorium is short. But what is likely to be the most important thing here for the fall? Loss of power or loss of tone. So you analyze it that way. Then from power you go to whether peripheral nerve or muscle or neuromuscular junction. But I think the first sentence should be that there is loss of power and or tone.
Now, can any of this happen acutely? Acute loss of power coming with falling down. He will come with not moving. This has happened in a short time. So origin is also important. Has it been suddenly one fine morning? Okay, or has it come up over 2-3 days? Each small things makes a lot of difference.
So Yashodhan, you may not know this, but that's what we wanted. That what is the timetable over those 15 days? So on day, like tripping and falling initially, then how many days of tripping and falling before the next problem of difficulty in walking up and down stairs, or then you said generalized weakness. So do you know any idea of this timetable or you don't know? Okay. So this is important because we want to know what is the type of progression, and as sir said, onset. Now the other thing is the word tripping. So tripping, what does tripping mean specifically? You can talk in your vernacular language, because if the parent has said this, then it narrows down many of your earlier DDs which we talked of reasons of falling. So what is tripping?
Suppose I am climbing this and I suddenly fall down. Is it tripping?
So tripping means your coordination between the two legs is going wrong. That is tripping. Correct? So that means either your one leg is not lifting properly, or that leg is not striking the heel properly and is striking the toes first, or the other leg is getting entangled in this leg, something like this. So then all your incoordination and ataxia and vision problems and all those go away, and you start looking at a tone or a peripheral, as you said, peripheral weakness. Suppose I have developed a foot drop. I'm going to trip and fall, right? So if you remember in your pediatrics, where does this falling come, which disease comes as a falling? Which neurological disease? One of the earliest presentations at 2-3 years is frequent falls. When you pick it up at 4-5 years of age. Duchenne's, classically Duchenne's come as frequent falls.
And therefore we want to know how was the child prior to that. Most of the problem don't start acutely like this. So whether the child started walking in time, running in time, and therefore the story always starts with how well he was, and well in every direction. Okay, we expect this child not to be so normal to begin with also. The parents came to know only because when he started falling down. But was there something
What do you think? He was
happening?
absolutely normal before this?
So we have seen videos of the child. So we have seen videos of the child. The mother was not able to articulate properly that how the weakness has progressed. But they have taken videos, some random videos in her household playing. So there was one video before, like a month before, where the child was going up and down the stairs very freely. And then they have showed a video 10, 12 days back, very casually taken, but the child is very carefully climbing up, carefully climbing down. And then they are able, when asked in depth, then they are able to notice, yeah, this has also happened, this has also happened. So they are not sure how this exactly has gone up.
Because all muscle disorders are almost never acute. So they are slowly coming up. Okay.
So now, do you think this is GBS? Means, or typical ascending paralysis? GBS means, what I am trying to say is, where's the anatomy? I am asking you whether the anatomy is upper motor neuron or lower motor neuron. Here?
Lower motor neuron.
Okay. Why?
Weakness is more of the lower limb.
He said lower limb and upper limb. Respiration also there's a use.
Later respiration is also involved. The child. So later on, respiration has also gradually involved, and the child actually has come in with complaints of increased work of breathing, not for the generalized weakness. They thought the generalized weakness is related to reduced intake, but when the child had difficulty in breathing, then that's when they presented.
No, but when you said increased work of breathing, you also said he was taking slow deep breaths.
Yes, initially when the child was asleep, the mother noticed that the child is taking slow and deep breaths, and there was effortful breathing on the child's part, and later this has worsened, and on the day of presentation the child is taking very slow breaths according to mother, and very deep, there are effortful breathing.
Okay. Does anything come to your mind when he is saying this? When do you see slow breaths? Respiratory distress is slow breaths or fast breaths? Fast breaths. So when do you see slow breaths?
CNS involvement.
Yeah.
Head injury or the
respiratory center involvement.
Respiratory center involvement. So one is that, then
nerve injury to the, which is phrenic nerve injury can cause.
So phrenic nerve injury will cause a paralysis. So see, if any of the components of the respiratory system are knocked off, it wants to compensate. So it's going to breathe faster to try and compensate. Right? So slow breathing is a very funny observation and a very different observation, which somehow takes you to the higher up. But then how is the sensorium of this child? Is he?
So on the day of presentation, the sensorium was poor. Her GCS was 7/15. So when the child had presented, she was drowsy. The sensorium was around 7-8. Her saturation was around 90. Her respiratory rate was around 10 to 12. So basically a respiratory failure, secondary to maybe because this is a paralysis which is involving all the four limbs. Maybe now this has also involved the phrenic nerves, and that has caused respiratory failure. And now the child has presented as worsened breathing and drowsy sensorium.
I think the first thing that came to my mind when you said this is, what is weakness really? Is the weakness refers to a neurological weakness of a paresis? or it's non-neurological. That's my first thing. Now weakness is weakness in pediatric practice is a normal thin child is called by the mother as a weak child. Why? Because he's not gaining weight well. And he said, "No, बहुत weak hai. He may be as strong." And every time I have seen a normal thin child brought to me as a weak child, I ask the mother only one question: by evening who gets tired first, you or the child? He said, "My child never gets tired." Then who is weak? So weakness is, you need to be sure what weakness means. So first make sure, does weakness mean some part of the body is not moving? That brings you to a neurological problem. And I think when this started in 15 days' time, it can't be non-neurological. It has to be neurological. But first confirm that there is a paresis. Once you get a paresis, you go peripheral or central. Peripheral nerve or maybe the anterior onset, you straight away get that. Acute onset fits well, more anterior onset. Progressive, yes, more anterior onset. Okay, so you get a GBS there. Okay, if you just go that way, then you get that. Muscle is chronic. So you get a story, he started standing late, he started climbing late, and now he is tripping. Maybe that's a muscle. So I think that's the way we would have gone by.
Sir, only I thought that this respiratory rate 10 to 12 is always seen in CNS depression.
Yes, that is so. But as I said, if the story starts from peripheral weakness, then that looks very unusual, unless it has even reached higher up. But then you would have some changes in the sensorium. Not only that. Okay. Let's see what happens on
examination finding.
See, again, the point we are making is history has to be extremely in details. Okay. And every time you think, what does weakness mean? We need to start asking the parent. We have already said, every time the history says cold and cough, is there running nose? No. Is there blocked nose? No. Then what is cold? There is no cold at all. And then what is cough? Is he coughing? No. He is making noise. Noisy breathing is called cold and cough, and the diagnosis may be a laryngomalacia and nothing else. But the story is cold and cough. So we need to look at carefully on that.
Regarding the breathing, is the mother's observation.
Look that,
mother's observation that he's breathing fast and low and something like that. All she must have said is he has difficulty in breathing, which she's saying is deep and slow. But we will on examination find some.
He mentioned that even they thought slow and deep. Now let's see, he's written here rate is 12 per minute. Respiratory rate 12 per minute. Okay, go on.
So when the child presented, she was afebrile and drowsy. She was a sick-looking child with a heart rate of 102 per minute, respiratory rate of 12 per minute, and she was taking effortful but regular breaths. Saturation was 90% on room air. Peripheral pulses were poorly felt. Central pulses were moderately felt. Extremities were cold. BP was 70/38. For her weight and height, it is for her age, it is less than 5th centile. Her blood sugar levels on presentation were 126, and there was no icterus, cyanosis, clubbing, lymphedema or edema. On anthropometry wise, the child is there is severe acute malnutrition. The nutritional history is poor. She is poor in calorie intake and poor in protein intake also.
Now see the fun again, that severe acute malnutrition, but he was all right 15 days back. That means we have just asked, "Pehle acha tha kya?" "Haan, acha tha." That is not right. Okay. We need to get into every small detail. Okay. How can this child be normal prior to 15 days? Not possible. But you will say, "No, but mother said he was all right." But what is all right? For me, if I failed twice, it's all right. Third time I will pass. Is that all right? No. So I think we need to look at that carefully.
Okay, sir, now I want some thoughts, sir.
And this is happening repeatedly because the weight and height concept is not taken. They go by weight less than 3rd percentile, height less than 2nd, something like that. And therefore it is called as acute severe malnutrition. Now if weight and height, height are correlated with each other, then you will find that the weight is not that bad for the given height. If you compare with age, then it will be low. Because if you see a severe acute malnutrition, as we have said earlier, clinically also he has to be malnourished. That means subcutaneous fat is lost, muscle mass is poor, maybe even the fat is getting lost from face. So if they are not there, then judging only by weight, which is also according to the age, because the weight does not depend upon age, the weight depends upon your height. My height and somebody else's height will determine our weight also. So here the weight was
10 kg.
10 kg and height is 96 centimeters. 96 is good for, it's like a 3-year-old child. So for 3 years, of course, it is, 10th is quite low.
I want you to focus on the left side readings and tell me what all thoughts come to your mind.
Sir, examination part looks like decompensated, so mostly due to the respiratory failure part.
Decompensated shock due to respiratory failure. Okay. Anything else? So, any other thoughts? So, in respiratory failure, what do you want the SpO2 to be? 90 is respiratory failure.
Respiratory rate is also.
Rate is high or low?
Low.
That's what I'm saying. What means, I was trying to point out something different. I was saying, see, for you to call it decompensated shock secondary to respiratory failure, the respiratory failure has to be clinically obvious. He should be cyanosed clinically, SpO2 should be less than 85 for you to call it respiratory failure clinically. Otherwise, respiratory failure is this respiratory distress has to have a lot of tachypnea. So this is not happening. So the only situation where you have a low respiratory rate is central depression. Okay, that brings you to a thought process whether even the cardio, meaning the BP part, is a central affection. So is it all the vasomotor centers and the respiratory center, are they being affected, leading to depression of both the BP and the respiration, is what I'm trying to say, right?
Also, when you say the respiratory rate is low, you must also speak a word about the intercostal movements and the diaphragm. Whether both of them are functioning or the diaphragm, the stomach is rising up properly, telling you that the diaphragm breathing is good, or whether the intercostal movements are not good, whichever. Because please remember, what is more important as far as breathing is concerned, the diaphragm or the intercostals? Diaphragm. 80% of breathing is given by diaphragm. So if the stomach is not coming up with every inspiration, that means the diaphragm is at fault. And this is a medical emergency because he can go in respiratory failure anytime. If, however, the excursion is good and the diaphragm is also, the stomach is also coming up, that means there is fair excursion, fair oxygenation. So do you have any comment on the type of breathing?
So it was thoraco-abdominal breathing, but the intercostal retractions weren't prominent.
Good.
So on head-to-toe examination, it was otherwise normal. There were no spinal deformities suggestive of any to rule out any gibbous, or there was no any paraspinal swellings. There was any neck swellings that would rule out any extradural or extraspinal abscesses or any collections that might be compressing the spinal cord. There were no rashes, there were no bite marks that were visible. On CNS examination, when the child presented, her GCS was around 7. So immediately the child was intubated. So this was her on presentation. The child had a GCS of 7. The pupils were bilaterally equal, reacting to light. There were no any obvious cranial nerve deficits, but obviously the entire examination could not be done. Her power was 1/5. She had, the tone was hypotonic in all 4 limbs. Her power was 1/5 in bilateral upper limbs, 3/5 in right lower limb. She was able to move it, 2/5 in left lower limb, and the reflexes were 3+, actually brisk reflexes with extensor plantars, and bilateral ill-sustained clonus was seen. So there were no meningeal signs, there were no cerebellar signs, there were no obvious cranial nerve deficits, and because the child was so drowsy and almost immediately got intubated, the sensory examination in this child could not be done.
Okay. So now this is upper motor neuron or lower motor neuron? Upper motor, but there is hypotonia and there's hypotonia in all 4 limbs.
And power is also diminished.
Power is low. He is in spinal shock. So why do you say it's upper motor neuron? What is point? Plantar extensor is wrong technique.
Reflexes.
Brisk reflexes. No, brisk reflexes you never get in lower motor neuron. So that's why this is in spinal shock.
And clonus is also
Clonus is also there. So upper motor neuron, now where is the level of the lesion?
So this presentation is of a progressive flaccid quadriparesis, which is ascending in nature, with no bladder bowel involvement, with no cranial nerve involvement, but the child is presented in spinal shock. So I have localized the lesion in upper spinal cord. Maybe the cervical spinal cord is getting involved. That will explain quadriparesis. That will explain the respiratory depression and respiratory failure, which has in turn caused hypoxia, which has in turn caused drowsy sensorium, and the spinal shock phase that explains the brisk reflexes. And there is no bladder bowel involvement, and the bilateral plantar extensor and ill-sustained clonus against. There is no history of root pain, there is no history of fever, there is no gibbous, there is no Cox or Cox contact, there are no sensory, there is no history of sensory system involvement, there is no tingling, numbness, so roots, there is no root involvement. So probably a very higher cervical cord lesion, only that can that can explain.
So see, maybe because you know the diagnosis, you can argue that way. But the point is that today this child has altered sensorium. So to say that altered sensorium is because of respiratory failure, which is because of high cervical lesion. So that high cervical, whenever it causes an initial problem in respiration, there will be a phase of rapid breathing. You can never have low respiratory rate because of any phrenic nerve or whatever. Whatever nerve is knocked off, you will compensate and you will have rapid breathing trying to compensate. Then when you fail to the extent that the muscles are exhausted, then your respiratory rate will go down because of your central this thing. So respiratory rate goes down either as pre-terminal or as central. So we don't have that history of that phase when this child was in respiratory distress, right? We don't have any such history.
No history.
And also cervical cord means what part? Is it the motor portion, the cervical? You know, there are many tracts there. So which tract is involved or all the tract is involved? Why bladder and bowel is spared in the spinal cord region? It's only the motor tract and sensory are preserved. That means there is an anterior lesion or selective motor region is going to be very difficult.
No, selective as in he's saying that sensory we don't know because we couldn't examine. Bladder bowel, your point is right, but sensory could be involved, we don't know.
I think the very fact that the story starts with not an acute onset neurological problem, but slowly coming up. For example, there was first only some tripping, falling, okay. To that extent, I think at that stage there must have been a respiratory distress. If that was a higher cervical problem and because of which the upper motor neuron lesions are coming up. Okay, we said that power tone, etc., that is getting upset. It starts making him fall down, at which time he's managed to breathe, keep his oxygen reasonably normal with increased respiratory rate. But then that ultimately it further progresses and then it starts getting hypoxic. When he gets hypoxic, he gets drowsy. Then he gets a higher failure, a medullary failure, a brainstem failure, and then he goes into shock. So I see that it's not an acute event, but a subacute event. And in that, the parents may not have observed the high respiratory rate, but they have now come with drowsiness, etc. Again, there is no seizure, so cortex is still preserved. So it has been a brainstem affection. Okay, as the whole story goes. In that case, I was wondering whether the myelitis has also an encephalitis. And you call it an encephalomyelitis. Okay. Or whether it was only a respiratory failure doing it. Respiratory failure doing with hypoxia would not have just picked up a brainstem. So my diagnosis is a myelitis with brainstem encephalitis. Okay, more than a respiratory failure causing drowsiness. It appears to be so, right?
And also, if there was so, why there has been an apparent ascending order, started with lower limbs, then it went on to, so there was something which we may not be able to explain. Okay, that means which part of the center of the spinal cord got affected first, so that the lower limbs were involved, then the upper limbs. So was it? We don't know that. If the history of lower limb affected first and upper limb getting affected later is true. And over a period of 15 days, if the events have occurred, will he go in spinal shock?
The rest of the examination was normal. There were no any significant findings. So my initial impression is a 3-year, 11-month-old female child, immunized till date with no significant past history, presented in acute flaccid paralysis with distal to proximal progression with preserved reflexes, which is most likely a case of acute transverse myelitis. Second is Guillain-Barré syndrome, and third is maybe a compressive myelopathy secondary to a vascular or bony malformations. But none of the history goes in favor of compressive myelopathy. It usually goes in favor of non-compressive myelopathies, but that's why I've kept it third. Guillain-Barré syndrome is second because the reflexes are preserved. So it is less likely to have preserved reflexes in a Guillain-Barré syndrome. So,
and actually preserved as in you actually have reflexes 3+. So that is against GBS, right?
Any lower motor neuron is out.
So your acute transverse myelitis stays, and as sir rightly gave the reasons, it is plus brainstem encephalitis possibly.
But in transverse myelitis there is pyramidal involvement, bladder bowel involvement and sensory involvement. So if there was no sensory symptoms, at least on examination you should have been able to find out some sensory finds, and not only that, level for transverse myelitis we often depend upon the level.
So now because this is high cervical, he is postulating.
But bladder bowel spared and no sensory disturbance whatsoever. For transverse myelitis, all the three elements should be affected.
And I think therefore it looks like an ADEM, okay, where the E part is not primarily, but the spinal cord has come up further, and even E part is localized, not all over the cortex. And I think to me it's like an ADEM, immunological process, reasonably acute onset, but over a few days worsening. And I think diagnosis would be theoretically an ADEM, and an MRI should show certainly the inflammatory lesions both in the brainstem and the I think, but certainly it's not compressive myelopathy. It would have taken a long time and it would not have caused the respiratory problems at all. It's not a Guillain-Barré also, because he would have gone down with tachypnic and failure and not
no lower motor neuron at all.
So that is out. So it has to be, and I think, a brainstem encephalitis with myelitis. We call it an ADEM. So what treatment has, what?
There's one of the brainstem encephalitis is Bickerstaff encephalitis, which I vaguely remember was a type of GBS, but we'll have to see whether they have hyperreflexia, because otherwise that's a very odd point in GBS.
Moving on to investigations, the initial CBC was HB of 10.4, hematocrit of 33.7, counts were 11,400 and platelets of 2 lakh.
What was abnormal, you tell us? These are all okay, routine?
Okay, CSF examination was also done, sir, because initially the thought process was also encephalitis, maybe a myelitis with encephalitis, but the CSF RM was also normal, CSF culture also showed no growth, so the imaging was done. So the MRI was done, and MRI was suggestive of, MRI brain showed no abnormalities. The MRI cervical spine showed abnormal subluxation of C1, and the child had os odontodium relative to the dens, and that had subluxated with increased atlantodental interval. There was also hypoplastic dens causing effacement of the anterior subarachnoid space and compression over the cervicomedullary junction. And this has resulted in abnormal intramedullary foci and cystic areas at the cervicomedullary and the C1-C2 junction. That was suggestive of myelomalacia, secondary to cervical, secondary to compressive myelopathy. So this is our MRI, which is suggestive of higher cervical lesions, C1, basically an os odontodium along with the hypoplastic dens process, which has gone into possibly a spontaneous subluxation causing cervicomyelomalacia. And then the child had presented to us in the extreme later stages, so that the child got intubated directly.
So you all have discussed it with the neurology people. So what I'm asking is this myelomalacia, has it happened in these 15 days, as in when did the subluxation happen? It's a event which happened 15 days back or a long time back, and then over time the myelomalacia has happened? Ring one.
So there was,
getting my point?
Yeah, there was no any history of trauma. There was no any. This was also an intriguing case for us. But this was discussed in our...
Means my logical thinking is that the malacia part, the myelomalacia part should take a little time. It shouldn't happen so quickly. You said there was increased space and all that, which means that there was, destruction of tissue over a period of time by compression. So I thought whether that should have taken more time. So it's even before the 15 days, whether that process was happening.
The mother, while giving history, is sure that the child was absolutely all right.
No, there may not be symptoms, but because again, if it was an acute event, if this acutely subluxated, then the history should have been a very acute neurodeficit, no? That way. What I mean is, see, these cystic areas take time to come up, na, is what I am saying. So I am requesting you, we also don't know the details of all these pathologies, but discuss with Dr. Arpita or whoever, what is the time frame of this pathology?
So this case was discussed in our neuro radio meet also, and they have also come to this conclusion. This is a subacute quadriparesis which has developed over the time, but the history, that the presentation of the child is, even though it is 15 days, this must have progressed over a long period of time, because
they said that, that's what I'm asking. That's exactly what I'm asking.
Yes.
That this is subacute. It can't be 15-day story. All the cystic areas and all take time to develop.
I think I will have to check up the statement that I am making, but cervicomedullary junction is a cruciate hemiplasia. That is what is called as. Just check on that, because cervicomedullary. See, when we talk of hemiplegia, we start from cortex, subcortical, etc. We come down to cervicomedullary. And to me, if I know rightly, cervicomedullary is a hemiparesis and not a paraparesis. Okay, but we'll have to check that. Cervicomedullary junction also is known to cause a hemiplegia.
Sir, so probably it would depend on a unilateral or a bilateral lesion there. So here they are trying to say that because the dens is subluxation of C1, so I think the whole cord is
so I think the subluxation of C1 indicates that there has been a congenital functional element which has now suddenly worsened. Okay, it's not an atlantoaxial dislocation, but subluxation, almost like a subluxation of any joint. So possibly these are small malformations which have now acutely manifested, maybe by some occult trauma or whatever. We don't know really that. But again, a compressive myelopathy would not be acute onset unless that lesion has suddenly increased. Now, why should it suddenly increase? Either it has a hemorrhage inside or it has been a severe inflammation inside. So, which looks little unusual, but yes, I think finally you have an MRI showing all that. Yes.
Myelopathies are usually asymmetrical, exactly symmetrical on both the sides, at least to start with asymmetrical. Pressing equally on the right side and left side. Anyway, we have to accept what they say, but clinically it would have been difficult to explain all this.
So the final diagnosis is progressive flaccid subacute quadriparesis with respiratory involvement secondary to C1 and os odontodium dislocation in a hypoplastic dense process.
Okay. Okay, thank you. So,
I think just summarize today's both cases. The first case was a very well presented and it was simple to analyze, and you had a congenital cyanotic heart disease, and the history clearly showed that there has to be a right to left shunting, there has to be a pulmonary obstructive lesion, and there is no cardiac failure, so there has to be an outlet to the right ventricle. And putting all that together, the diagnosis of a Fallot's tetralogy was made, and we said clinically Fallot's physiology, and we discussed the different lesions causing Fallot's physiology, and we said the most likely in this child is a Fallot's tetralogy, and that was proved. The second case was a very interesting one to present with, and I think the story started in a normal child, reasonably acute onset, but progressively within next 2 weeks progressing fast, and the story starts with tripping and falling. To that extent we started thinking, and the story said generalized weakness. We made a point that whenever there is a weakness as a statement, we want to be sure whether it's a neurological weakness or a general weakness. Now, generalized neurological weakness meant almost upper and both lower limbs, and therefore when there was nothing higher up there, any symptomatology, it was rightly considered that it must have been at a higher cervical lesion, and we discussed the probability of a more lower motor neuron. But when we said upper and lower limbs both, we went up to the upper cervical region, and then we wondered why was this child went into a respiratory failure and shock. So respiratory failure because the respiratory rate was very much low, and shock. So we said that this was a brain stem involvement. So we thought that you are dealing with a kind of a transverse myelitis because it was a cervical lesion, but it caused a brain stem lesion, and therefore we said that it must be a reasonably to call an ADEM, a spine, the transverse myelitis plus the brain stem affection. However, on further investigation, it came out to be a cervical lesion and a medullary lesion, but of a different kind. And what different kind? On final analysis, it looks like that there has been a congenital malformations on this child. And we do not know what suddenly made it as an acute presentation, but I imagine even an occult trauma or pulling up of the head or turning somewhere might have made a difference. For example, a child of a Down syndrome who has a severe hypotonia is likely to get an atlantoaxial dislocation all of a sudden because he is severely hypotonic and many structures in the body could be hypotonic. So here MRI showed that there was certainly some cyst hypoplastic lesions, and therefore the final impression was a congenital malformations which came up as an acute manifestation of a cervical spinal cord and the brainstem. I'm sure we would not have imagined that this could have been a congenital malformation, etc. Final impression on MRI was also compressive myelopathy. Again, by classical compressive myelopathy, we mean something gradually worsening. This happened rather in a very short time. So finally, it must have been compression and also myelopathy. But the question is, what kind of acute manifestation came up in a compressive myelopathy? To me, therefore, some congenital lesion which became suddenly enlarged or suddenly compressing. I don't know whether it's a movable lesion, it must have been some occult trauma causing it, and obviously there was no hemorrhage or no inflammation. So I think this is one good case where a clinical diagnosis based on average, normal, sometimes seen such patient would have been an ADEM-like. However, these are the cases where further investigations are a must, whether you call it an ADEM or otherwise. And while the diagnosis, before we saw the report, we did say that we would certainly do an MRI because we said it's cervical plus brainstem. And there we got a surprise diagnosis. Medicine is uncertain, but I think our thought processes led us to a cervical spinal cord and also the brainstem, which was reasonably right. We would not have thought of congenital lesions worsening, etc. And even today we don't know what made this child suddenly come up 2 weeks back and then progress so fast to cause a shock and respiratory failure. But quite an interesting case. Good that you brought this case, because this tells us that we can still reach a reasonably correct diagnosis, but not necessarily etiology. After all, what's the etiology of ADEM? Some inflammation, non-infective, probably immune, so we go IV, IG, whatever, steroids. So ultimately, anatomy and pathology could be also reasonably arrived at in this child, though the ultimate final diagnosis was a congenital malformation with some acute worsening. But a good case that you presented, yes? I think...
So thank you. We stop the class today. So thank you all our online viewers. Thank you online faculty, Dr. Palni Raman and others who've been interacting. And we once again thank Aristo Pharma for their educational grant, which helps us to live webcast these classes. We meet once again next Thursday evening at 6 p.m. Okay, thank you.
I think that's one request.